Hi, greetings. My name is Craig Lammer. I'm an executive director for the Autoimmune Hepatitis Association. I'm also a hepatologist at Indiana University. Once again, I want to welcome Dr. Ermel. He's joining us again to talk on the topic of COVID for the 2022 AIH Patient Conference. Dr. Ermel, thank you so much for joining with us today.
Oh, thanks for having me.
Just so we can get the record straight, most of our members have met you at some course along the lines of the pandemic that is ongoing. Can you tell us a little bit about what infectious disease is and that title?
Well, I mean, infectious disease, much like hepatology, is a subspecialty within internal medicine where we specialize in infections. And as we like to say in infectious disease, everything is infectious. So we see a lot of things, and most of us see pretty much just infections in general. Some of us subspecialize within that and work with one particular pathogen, but it's an ever-changing kind of wide variety of things that we always see. So.
Great. No, thank you. I think it's relevant and it definitely identifies you as probably an expert in this field of COVID, particularly in the pandemic. And that's why we look to experts like you to kind of lead us in some of these vulnerable populations, such as autoimmune hepatitis, through this. So again, thank you so much. Maybe I could start by asking you to maybe even editorialize the idea of what stage are we at with this pandemic? And again, from an infectious disease doctor's lens.
Yeah, I mean, if I look at it, when you think about this question, I look at it from two different angles. And one is kind of the epidemiology and what we would see in a virus like this. So it looks more like it's moving towards an endemic type phase, though we are still seeing, I think, a few more peaks and valleys than you would expect relative to other endemic viruses that we see. So if we are moving towards that, it's very early. The other facet I look at is actually what that means. Why are you asking the question? And it's almost like culturally, I have to look into like, well, do we label it this because it's behavior changing, or why do we focus on this definition? Because if you think about how we've behaved, it's, culturally, I think many of us were already into endemicity a long time ago. So I think that's the other thing is that I think from the cultural point of view, we kind of moved into endemicity a long time ago, versus what we still think of this as being a pandemic. Just a few too many waves, I think,
Right.
for this to be endemic. But
Yeah, that makes sense. And you brought up this idea of other viruses. What other comparisons could you make to such as something like the flu virus that we see seasonally or?
yeah, I mean, if you look at other respiratory viruses in general, most of them have their seasons, they have their peaks, they've established their physiology. Occasionally, much like influenza, which is kind of probably the easiest comparison, you see outbreaks of, like avian flu and other things that we've seen recently where we've been concerned, and then we have to adapt vaccines. But if you look at the prevalence of SARS-CoV-2 right now, it is still so much higher than even like influenza during some of our peak seasons, where like the CDC having looked back from October to now, if you look at all the tests that have been sent, the cumulative positive rate has been like 1.8%, which is, I don't know that we've reached that that valley for a while in COVID. When we get down to like that 2 or 3%, we're pretty excited, but then we also find no one's testing themselves. And then but then we hit a surge and we're well above that. I mean, you get areas where 20% of tests are coming back positive. So it's the closest thing to draw, but that kind of comparison, but it's actually still very different from influenza. A little worse during the winter than it is during the summer, but if you see our recent peaks, it's actually still establishing itself with new variants, no matter what season.
Yeah, and maybe because you brought up that idea of variants, it seems like there's been a shift, and this is a challenging thing for me as a hepatologist, that there's just, again, still just as much COVID news coming out every day, and it seems to be directed around therapies and variants and outcomes. Is there a dominant strain in the US, and has it changed recently? And then the follow-up piece is everybody wants to know, are we still protected regarding these, given our vaccine status?
Well, there is, I mean, Omicron has become dominant across the US. If you look at like percentage of isolates, it kind of did the expected takeover ever since January when we had the last very large surge. What we have now started to see, where it's only in the US, based on the last genomic surveillance, about 20 to 30%, the BA5 variant or even 4, almost equal parts within our population, are just now starting to appear, maybe accounting for the recent increase in positivity rate. So we're still seeing, similar to what we see when we see in other areas of the world where it starts to rise and there's a variant, we tend to be kind of a little bit later. But that's what we're seeing right now. So we are seeing kind of the usual variant takeover that we saw in subsequent surges.
Gotcha. And this BA5 you brought up, and again, part of those news stories is telling me about the involvement of the lungs, and this seems to be a good marker of severity of illness. Is that true, or is that, or should we be looking at it differently?
Yeah, I mean, I don't know that the physiology is too different with BA5 versus the others, even though, transmissibility seems to be much higher with these than subsequent variants. I mean, really, we learned that lesson with Omicron, I think, when the original Omicron variants appeared. But when you look, it's disease severity is always a challenging thing to look at, because it's so dependent upon the population that you're studying and what their prior COVID infections look like, what their resources look like. South Africa saw a massive wave of infections, but yet only saw a trickle of hospitalizations and then even fewer deaths. But in areas that had an older population, they did see a slight increase in hospitalizations and a slight increase in deaths. So they weren't quite spared. And so then your population, depending upon age and then also vaccination rate as well, what some theorized in South Africa was that they had such bad Omicron waves first, and then a certain portion of patient population was vaccinated, and they continued vaccine campaigns, that they developed such a hybrid immunity that they feel that it may have actually prevented a little more disease. When you see that in other populations that are heavily vaccinated, they just tend to become infected, but again, the disease was still modulated by the vaccine. It's not that severe disease increased, but it didn't stop transmissibility.
Right. Okay. So I think I understand. I just want to make sure that I'm clear. So vaccinated individuals and or those that are being infected, we're still confirming some protection, particularly, patients that are being infected with new variants are having less severe infections, less hospitalizations, and less death, hopefully. Is that what the trend seems to be?
Yeah, I mean, the vaccines do seem to offer some level of protection from severe disease, hospitalization and death rates, which again was always the goal of the vaccines. It's just what's unfortunate is that at least hasn't been demonstrated that transmissibility has been reduced. And so we're still seeing the virus transmitted very easily, but less people are becoming ill. And that's reflected in the fact that we're probably undercounting cases because, people were, been worried about testing at home and are we missing these cases? And from my standpoint, I said, well, I would love to know every single case in this county. However, if they're able to stay home and live through it and they just had a positive antigen test, isn't that kind of where we wanted to go with this? So I think,
Right.
it's sad that we still have so much disease, but if people are able to recover meaningfully, I think then that is an achievement.
That's right. So again, from my perspective, I was also a little bit downtrodden that, well, we don't know the number of true cases. But again, you're right. If people are at home testing and they're staying home, then at least that's a reassuring phenomenon, no matter what the overall case burden is that we know about, right?
Exactly.
Yeah. So, speaking of vaccines, it just seemed like we were going to have some kind of reinvention of this vaccine, maybe targeting some Omicron kind of component. What I'm hearing, though, is it almost seems like it's too late for anything targeting Omicron. What are your thoughts about that? And is there any other kind of perspective that vaccine manufacturers are taking in this direction?
Yeah, I don't know the details of like the mRNA manufacturing process well enough to just when you get down to some of these, it's a question of logistics. How
Sure.
physically, how quickly can they produce these? The other is that we do have Omicron specific vaccines. Two were announced recently, just again through press releases saying that they seem to you develop nice neutralizing antibodies to these, whether and bores out in protection, transmissibility still yet to be seen. But it was a similar technology that then had to be approved by the FDA all over again, which got recently greenlit to be able to be produced, but they're still saying it's not, they're going to have anything till October, and will we be dealing with a different variant by then? I think what we can hope for is that the vaccines do kind of what we always hope the vaccines will do with influenza, which still provide some partial protection that keeps people out of the hospitals. In that concept, I have a hard time stressing that to people who haven't looked at the history of like flu vaccines, where even with flu vaccines that there was type mismatch, we still saw some protection. There was still a lower likelihood of being hospitalized and dying of influenza, even if there was type mismatch in our vaccinated populations. And I think that's something we're going to still see in COVID. What I'm excited about is that like upcoming, we'll have other options such as protein subunit and other vaccine technologies that are turning out to be very effective, and just will help with that distribution and adding to that kind of our repertoire of vaccines.
And when you say protein subunit, just for our members to understand that, is that more of a vaccine that would be widely, at least to work against multiple different variants in the future? Is that the idea?
Yeah, I mean, you could potentially, similar to what they've done with the mRNA-based vaccines, mix proteins from the various, variants. And they're just, you produce them separately and are able to add them into the same injection, which is essentially what the bivalent mRNA vaccines are as well. So you'll be getting that mix of proteins presented to the immune system, hopefully establishing some protection to all the variants that are represented.
I see. Okay, fantastic. So since we're still on the topic of vaccination, as we represent a very large proportion of individuals that are immunosuppressed with varying levels, everything from very low dose azathioprine all the way up to probably multiple therapies, including Cellcept, tacrolimus, sirolimus, even high courses of prednisone and budesonide. These immunosuppressed patients, as they have followed along with us, and again, over the course of this pandemic, have gone through a number of different vaccination series. And again, I'm hearing now with patients that had already gotten their true booster dose, so it would have been their fourth dose, they're coming up closer to 6 months. Do we think that we'll have any further guidance on boosting in the future, come fall, going into winter, or is this something yet to be further clarified?
Yeah, I think there's hopefully in the upcoming 2 to 3 months, we'll get some clarity on that. I have not been recommending in general like a fifth booster dose until at least early fall if we don't have another option. So I think what really, the way I look at it is that if people are able to kind of wait until we have our kind of more Omicron specific and other vaccines, that will count as kind of like that fifth booster. You'll have some of the retained memory from the original SARS-CoV-2 strain or variant that was included in the vaccine that'll be part of the bivalent, and then with the new variants there as well. So that would be like the fifth booster. I am unaware of any data that suggests that like a fifth booster, at this point would provide that much more protection, especially with the change in the virus over time.
Sure. And in line with protection, again, many of our patients are trying to understand what they can do per se. And one thing that always flips back then is to their small children in the household. Any comments? We saw a change recently about the vaccination of very young children. Your general thoughts about recommendation for children at large, but also children of our membership pool that have kids that either go to daycare or any other exposure potentially. Is this something you would recommend?
I mean, I would recommend it. I mean, we have been able to demonstrate that it's very safe in children. Again, you do look at it as, is it really preventing that much transmissibility? But it may have some effect. We just haven't been able to measure it. And only recently, vaccines were available to children, and these contacts are a significant source of the virus. So I have generally recommended that children, especially of parents who have some sort of immunosuppressing condition, be vaccinated, as that's just another kind of wall to help to keep that bringing it from home.
Yeah. Yeah, no, that makes sense. And again, the follow-up questions, at least I get from patients, is really wanting to understand where am I most likely to get COVID? It sounds like a silly question, but it still seems like a lot of our members are curtailing their normal activity and trying to risk stratify on them for themselves. particularly trying to avoid behavior that maybe puts them at really high risk compared to those that are at least low or moderate. Any thoughts on different venues that may confer more risk than others, or what we've learned from the data the past couple of years?
Yeah, I think the one thing, and there may be more data on this, but the one thing that I have found somewhat disappointing that we haven't learned from this was identifying probably the spots, the behaviors that led to more infection. I think, clearly our like bars and indoor venues and things where people are in close proximity for, 2 to 3 hours at a time are incredibly high risk. Ironically, the reports of looking at like when masks were instituted in airlines, it turned out that travel related infections was much lower than we expected, which is what led to, I think, the stoppage of using masks on airlines. But gyms, and things like that are still high risk. However, I think it depends on the activity within the gym. I mean, early reports when the pandemic came out, we were able to contact trace better, found that the higher risk was actually not just going to the gym, it was actually going to the gym and participating in one of the small group classes that was in like a small room. I mean, I go to a gym that's very large and open, but there are some small group rooms that I will not go in. But in the large open area, I'm not particularly worried. I'm usually very separated from people. It's well ventilated. So I think there's ways of modifying that risk even within higher risk venues. Restaurants, depending on how they do their seating, can still be somewhat higher risk, but I think there's ways of just, if you're with your group and you're separated from others, I think you're probably lower risk.
Yeah, no, that's great insight, and I think just understanding that there are areas that, again, if the idea of catching this infection weighs heavy on them, maybe there are still behavior changes that can still be done. And again, I think I've seen more and more patients kind of taking an a la carte menu approach, and it's just a part of their risk stratification, right? But at least establishes some sense of control again. But beyond that, we do know that we have some other therapies for at least COVID. So this infection has changed. And we had you with us a little while ago, and we talked a little bit about two things: one, Paxlovid, and the second one, Shield. Maybe we could talk about that with our immunocompromised patients, because I've seen a few of my patients be prescribed Shield as another quote unquote layer of protection. Could you explain to those listening what Shield is, and maybe how it could be implemented in patients that are quote unquote high risk for severe disease?
So it's what's a monoclonal antibody, the same ones that would be infused with an IV infusion that we've heard about since early on in the pandemic for treatment. It is, but it's administered as two separate shots. So it's actually two separate antibodies that then are administered. And we think that protection in the original studies around the time of the Delta wave was actually that would last around 3 to 4 months of significant protection. The issue that has come up, which is common to all of our monoclonal antibodies, that the newer variants, then these antibodies don't protect as well against the newer variants. And so at this point, Shield has lost a little bit of its efficacy, and we're not really sure how. We're still, locally, we're still trying to prescribe this and get it out in the population. Is that, there's still some minute protection from it or offered by it, but and it's also a low risk medication. That's the other thing. Administering is very safe, so you don't lose much, just you may not gain much protection.
Gotcha. That makes sense. And maybe if we could highlight an area that we could theoretically think about using it if there is some benefit. But with Paxlovid as another medication used to treat COVID, before we get into that, could you tell us a little bit about Paxlovid, what it is, and what is the idea in terms of risk reduction for those infected?
Right. So Paxlovid actually, it's one of the first like virus specific therapies that we have. Which is nice. It was Pfizer developed this by screening all of their their small molecules and found that one was particularly effective against a particular protein in COVID called a protease, which basically just cuts up the protein so that then COVID, the virus can form itself within the cell. It's actually consistent of one drug being the protease inhibitor specific to COVID, and then it's co-formulated with another drug, which actually we take from HIV therapeutics, that's there to basically boost the levels of the COVID-specific protease inhibitor. And then that's what you take it for 5 days, and it actually just inhibits a part of the life cycle of COVID or of SARS-CoV-2. And so then that the one drug is acting just to make the more specific drug, very, very potent and to get those levels up there.
Yeah. And what kind of improvement do we see in the outcomes of patients prescribed Paxlovid?
Yeah, in the original trials, there was a very significant reduction in hospitalization and death in people who had mild and moderate COVID. So I think it was around the 80 to 90% range. This was studied before Omicron appeared, but they selected patients that had risk factors for having severe disease, but were caught during early disease, and they were administered Paxlovid, followed for about, I believe it was about a month. I'm trying to remember the specific study, and they noticed the patients who received Paxlovid actually had much lower risk of proceeding to hospitalization and death. So that was where the indication came from to administer this for a short period, so that the body could kind of catch up as far as there was any sort of immunity, or to like at least reduce reproduction of the virus.
Sure. And you made a comment about with these new variants. Is there any data to suggest that Paxlovid would lose efficacy, or that response for patients that are infected with the new variants?
Yeah, so far, the individuals, even the few rebound cases that I found where they were successfully had, they had virus they could sequence from initiation and also rebound. They noticed that there were no mutations within that particular gene, the protease gene, that would suggest resistance to Paxlovid. So at least in a handful of rebound cases, there was no evidence that the virus had become resistant in that case, which is always our concern when we see it reappear.
Yeah,
not demonstrated as the best the best techniques we have.
Right. And so since you've said the word rebound, we do get a lot of questions about rebound. What is viral rebound, and what are we seeing with Paxlovid?
Yeah, so there's a small percentage. This was not originally reported, but at the same time, it was smaller numbers, and the patients weren't followed for quite as long. But we see initial improvement. Individuals take their 5 days of Paxlovid, they're fine. And maybe around 9 days, they appear to rebound. They start to notice more symptoms, and they become positive again. This is actually a very small percentage of patients. It's probably right now of those that we've been able to identify about 1% or so. So it's not quite as high. But that's, again, only in studies. We don't know if we're really catching everyone. If you look at the percent that end up actually end up in the hospital from this, it's like 0.4 to 0.8, that are actually of all the rebound cases actually end up in developing severe disease. So again, it doesn't seem to clinically have as much significance as we were originally worried about, but people are noticing, this rebound phenomenon a little bit more than we had expected.
Certainly. And a very nuanced question with that, because I know our members pay attention to these details, and more for my own sake. My wife had COVID recently. She was given Paxlovid for a reason. We were testing throughout the course of this. Should we have tested her for any viral copies after completing the course, for the idea that could, in fact, patients become infectious again? What are your thoughts?
Yeah, I mean, I think part of that is you could do that. That's why in certain high-risk situations, like within healthcare, we're still wanting, at least antigen negativity before coming back to work, just because of that concern. I don't know if that's going to be feasible or really necessary in the general public.
Sure.
You could continue that 10-day quarantine just based on CDC guidelines, but I don't know how we'll integrate that into I guess behaviorally.
Yeah.
I think that's the big problem, right?
Right.
It's just I do that. There are only a certain number of individuals will do that. Right now, I'm not sure how advantageous that's going to be if you continue to feel fine. So
no, I think that makes sense. And just as a hepatologist, my soapbox for Paxlovid, because I am seeing that this drug is being prescribed more widely. Where we've talked before, it would go through a centralized process to have experts that know how to dose and treat and whether it's indicated. But I know that I received an email saying that this is widely available and other providers can prescribe for this now. it seems like there are some nuances with this medication that are definitely worth noting, at least in the liver disease specialty, patients with autoimmune hepatitis and those that are on immunomodulators. So as you were talking about, that ritonavir that's a part of this is metabolized through a specific enzyme in the liver. And the problem is that enzyme is also partly needed for the degradation of some immunosuppressants, specifically what are called the calcineurin inhibitors. So tacrolimus or Prograf, as well as cyclosporin, and then also the mTOR inhibitors, which includes everolimus and sirolimus. And I think less members of our organization are probably on it. These are kind of second and third line medications, but the problem is when you take this in conjunction with Paxlovid, there's some data that shows that at least the increases in things like Prograf can be found anywhere between 1.8 to almost 20-fold the normal dose that you would actually get and what we're detecting in your blood. The problem is then too, even if this is transient, those high levels can cause significant problems in terms of even renal toxicity, among other things as well. So I think most societies haven't really confirmed a strategy for patients that are obviously at some increased risk of severe disease. But how do you treat the immunosuppression if you're going to consider Paxlovid? This is something I would recommend you talk with your doctor. I think if a lot of us still try to avoid it, but it's also very individual. So I've seen strategies where patients will, or doctors will hold the medication if they think is feasible for even a few days and restart after day 6 or 7 of the Paxlovid therapy, with obviously following labs very carefully. Again, this can be kind of a slippery slope in the setting of transplant patients, but also even patients with autoimmune hepatitis that are very dependent on immunosuppression to prevent severe flare. So I did want to make it really known to our members that this is something, a conversation with your hepatologist, even if your primary care doctor is willing to prescribe Paxlovid for your COVID infection. And I also should say, Dr. Ermel, could you comment, how soon should Paxlovid be started to have any benefit in terms of onset of symptoms?
Yeah, so it's recommended that within 5 days of onset of symptoms. So, I've got, even friends who've asked me, they're diagnosed with COVID, and then they talk to me and I said, well, if today's day 1, you've got till day 5 that we can start this. And that's when we see the benefit. This is actually not uncommon to some of our other antiviral medications as well, specifically even for flu, where we just say, if it's not done within the first 3 days, there's no,
Right.
that was basically how it was studied. And so we try to get it within that window to maximize that benefit.
Yeah, no, I think that's great advice. The only other thing I will add to all that about Paxlovid is we also see some renal dosing approaches. So again, as there are some new providers that are prescribing this drug, sometimes some of the nuanced pieces aren't being followed carefully. So those are other things to bring up for our members as well. Shifting just a little bit before we let you go, Dr. Ermel, there's been one other thing that's been in the media recently that I've had patients also asking me about, and it's monkeypox. Could you just give me a 30-second overview of monkeypox? What do we need to know? What does the autoimmune or immunosuppressed community need to know? Or maybe we don't need to know anything.
Yeah, I guess, quickly, the monkeypox is an endemic virus, not here, but in Western Africa, kind of in that orthopox. So you're looking at smallpox and other animal pox, including cowpox, camelpox viruses. And, it causes, kind of this prodrome of fever, kind of the swollen glands, kind of the viral stuff that we all are used to from other stuff, and then leads to lesions in areas, usually in the areas of point of contact. So that's why there's been this big emphasis on trying to reduce actual physical contact, and then also trying to emphasize that a lot of this comes from prolonged close contact. We're seeing increased cases here in the US. It is not expanding as we saw like with SARS-CoV-2. What is fortunate is that out of you're looking at greater than 99% of these cases are resolving as they should, and people are perfectly healthy afterwards. And then we're not seeing hospitalizations really related to this at all. There's been, I think, too few immunosuppressed patients that have contracted this to really know how severe this is. But the early signals are that we're not seeing very severe disease in those patients. But again, it is a little rare. So we still warn people that those are the usual categories of people that we'd be concerned: immunosuppressed patients, whether it's from an infection or from medications, are still at high risk for the more severe disease, which can sometimes involve the lung and other organ systems.
Yeah. So I think that's great to know. And I think what I hear you're saying is that we probably shouldn't be too alarmed about this now. But again, it seems like we've all changed our approach to anything infectious anymore, as we've now changed beyond the pandemic. Is there anything else that we should be worried about this upcoming year in terms of infectious ramifications or pandemics or endemics for that matter?
Yeah.
Particularly maybe flu virus. Do we know what it's going to look like this season?
Yeah, I don't actually know. It's still been relatively mild, as far as I know, in other areas like the southern hemisphere, where we use to predict kind of northern hemisphere types. We have been somewhat worried about avian influenza, but have not seen as many like human outbreaks recently. So I think that's also reassuring. You know, some of the measures that we've taken from the SARS-CoV-2 pandemic, I think, do help in preventing other infections. A little bit increased mask wearing, more attention to sanitation, just hand sanitizers, things like that, some risk modification. So I can't tell you it won't be super severe, but I don't think so. I think what this did bring to the forefront was a lot of the debate over vaccine and just how important it is to keep up with flu vaccines. We're dealing with actually just meningitis, bacterial meningitis outbreaks in certain areas of the country, and just trying, and it's within specific groups. So we're trying to enforce, okay, get those vaccines because there are vaccines available. I mean, these things are like less than $1 through your health departments, and they're very safe. So I think that's the benefit. You can see it derived from the pandemic, just learning to reinforce vaccination. This is why we developed them. So can't predict the next pandemic. I wish I could.
Fair enough.
I'd be sitting here, but
of course,
yeah.
Of course. Well, again, Dr. Ermel, I want to thank you so much from the AHA and our members. You've been a true beacon for us throughout the course of this pandemic for the past couple of years. And again, your expertise is very valued. So once again, thank you for joining us.
Thank you for having me.